So we move on, and Dr. Rupak will discuss these. So her mentor. Welcome, Dr.
Yeah.
Rupak.
Uh, Thank you, Dr. Devdulal, for putting this excellent format of IC and making it more interactive. And thanks, Dr. Preeyam, also for excellent presentation. Now, the most important is that PVR management, one instrument which can handle all kind of PVR patients. So only one instrument if you have, you can manage, I think, all level of management. So this is just a routine information about the PVR. Average incidence is around 5 to 10 percent of the cases, but like, it varies from where you are practicing and what is your referral base. On that basis, it usually varies. This is the usual cases what we do get to see in different areas. And here in our audience, I think Dr. Natwar is here. Natwar, why don't you come in front? He is practicing in UK, so would like to have your few inputs that how do you see cases there. So at the end, we will take your few comments also. So now the most difficulties are starting from the placement of stroker, injury to the lens, retinal break during. These are all kind of complications can happen during PVR management. What you can expect or you cannot expect. So of which the most important part, I think these are the intrinsic contraction of the retina, the inability to deattach the retina. These are the most important area where you can focus for this. For anterior PVR, it is most difficult that where to place the trocar and cannula. So most of the cases, if you use 6 millimeter cannula, then you can overcome this. But make sure that your cannula is into the vitreous cavity before you start. This is causing lot of in case of PVR, it is already a complicated case. So if you make it more complicated by make a intraoperative choroidal detachment or intraoperative subretinal cannula, which is making your surgical time not only increasing, but again it is making the situation even more difficult for you. So be very careful from the very beginning, because you know what you are dealing with. So I'll just show you a few of those. So when you have this membrane, now you think about it can be of the anterior PVR or it can be a posterior PVR, it can be a combination of both. There can be a subretinal gliosis also. So any kind of situation you can have, and then you need to handle one by one. So if you have the posterior PVR, so it is better to have some amount of the dissection in the anterior part, then go down. So immediately if you try to go down, dig, and then try to fill up the membrane, it is not going to happen, because unless and until you remove it. So most importantly, the dissection, any kind of dissection, forget about the vitreoretinal dissection. Dissection has some amount of the basic principle of any surgery. So what happens, unless, and first thing is that if you don't see, don't operate. So unless until if you go and blindly go down, if the it is well covered, disc is not seeing, and you go down there and try to gasp the membrane, no, it is not going to happen, and invariably you will catch up of other tissue other than the membrane. So try to dissect of the anterior part as much as possible and go there. If needed, yes, some amount of the PFCL, that part PFCL will not help you in the dissection, but PFCL will some amount of the stabilization of the tissue wherever you are, and then you can, for the better visualization also, you can take the help. But again, with PFCL on, the dissection under PFCL is sometimes is easy, sometimes is difficult also, because if you have a fixed fold, then it will not go into that part, so it will come on the other part, causing that once you start pulling it off, the other part becomes where you are operating, that part becomes more bullous. So anyway, I mean, these are the small things which you need to take the decision intraoperatively. So let's see if this is the a small video which is showing a bimanual dissection of the membrane. So once we were discussing about that near the break where the lattices degenerations were there and they were not able to shave it. So that is for those who are early PVR, yes, you can get shave and then get away. But if you have a significant amount of the PVR near the break, So unless until you clear that area, it's very difficult to settle the retina, or the chance of recurrence is very high if you don't remove those membrane from the near the break. So in that, do not hesitate to go ahead for the bimanual dissection in that area. That bimanual dissection is as like similar to the PDA dissection, PDA membrane dissection. So yes, having this PFCL is an important tool. So you can, especially when you have a little bit of early PVR, that is the strategy should be a little difficult from the advanced PVR. Early PVR is sometimes it is even difficult to manage, because if you have the immature membrane, it's very difficult to visualize, very difficult to grasp that membrane. So these are the two basic difficulties what you are facing there. Sometimes if you are not able to dissect the membrane around the break, then you can put the PFCL and cover with the PFCL, go up to the break, and then start dissecting under PFCL with cutter or any other instrument. Now the problem is that if you use cutter under PFCL, then the PFCL will start decreasing in bubble. So give a little more amount of the PFCL and go in 2-3 steps. You may need to use little more amount of the PFCL, but doesn't matter if you can end up of the clearing that area much better. So I'll just show it. Yeah, this is just an example to show how I have covered it. This subretinal gliotic band management is very tricky in some situations. The most important is that location where the subretinal gliotic band is there, and how you are going to approach to that area, depending upon whether you are left-handed surgeon, you are right-handed surgeon, where you are sitting. So multiple other issues are there, and putting all of them together, you need to take the call. See here, just to show you, it's a very thin retina, thin retina, old retinal detachment, and significant amount of the, yes. This is a pull not by in one go. If you try to pull it in one go, there is always a chance of enlargement, yes. So this is by every time you take it out and then again go to the base, again pull it, so that the amount of the pull what you are pulling, so from that your forceps, the tenting should not be very high. If your tenting is high, it can actually act as a scissor to cut the retina, so that your the small hole what you have made is actually, you will end up having an incisional break. So these are the things, small things, if you need to take care of it. Yeah, in early PVR changes also, sometimes you can manage by doing a meticulous PVD. You can the immature membrane can take out along with this. So in this situation, a very slow and meticulous PVD induction also can help you a lot. And if you feel that there is some amount of the immature membrane is still remaining there, you can gently nudge with your even with the cutter. Cutter with the other side of the cutter, you can just simply rub it, and you can see where the membranes are getting. So if you have an immature membrane, suppose is here, and if you are nudging it here, you will see the whole retina, instead of coming, the whole fold moves. If the whole fold moves, then there is some amount of the membrane will be there. So by these small things, you can just identify how it is. Intrinsic contraction of the retina, you need to take the call according to as per the situations, and if needed, liberal retinotomy can save you for that kind of purposes, or a radial retinotomy also can help you in multiple radial retinotomy to settle the retina properly. So this is what sometimes you can land up of having a small central amount of the island of retina, but again you can manage it. Fixing the curled retinal edges, yes, it is possible. You can gently nudge it, because in this kind of situation, the more you can cover the amount of the exposed choroid is better. But again, most importantly, the curled retina, if you make it unfold, then the margin PVR development at later stage becomes less, so that the chance of recurrence becomes less. Thank you. These are few points which can continue the discussion.
Yeah, thank you, Dr. Rupak. Wonderful videos and tips. Dr. Aniruddha has a question.
I think we were discussing that sometimes vitreous is on the lattice margin where we can trim, but If the vitreous is in the break, then we have to take care, and if necessary, we can actually trim the edges. There is no harm rather than having vitreous on the edges of the hole. Rather, you trim it and then diatomize, and this is one thing. And PVD in TRD is very tricky. PVD, it is not the PVD what we normally induce. We have to see where the focal attachments are there. You have to be very careful. And in your case, I think PFCL would have helped, because putting the PFCL, you could see the other membranes which were first dissect those membrane, and then you can pull out the larger bits. I think that could have prevented.
Thank you, Dr. Rupak. Thank you.